Good morning, everybody. Welcome to this first session of today, which, as Amar said, is about long COVID and the economy. We've got some great speakers. I'm going to shortly hand over to our first speaker, who is Dr. Joseph Kwon. Joseph's a health economist at the Nuffield Department of Primary Care Health Sciences at the University of Oxford. His research background is in the health economic evaluation of geriatric prevention and care, but since January 2022, he's been doing a focused piece of research on the health economic impacts of long COVID. Now, I know many of us on this call who have had long COVID will have felt the personal economic impact of it in terms of how it affects our ability to work. But we're really delighted to have Joseph here today to share with us some about what he's been learning about the bigger picture on long COVID in the economy. So without further ado, I'm going to hand over to Joseph.
Thank you for this opportunity to present our research. So as Amy introduced, my name is Joseph. I'm a researcher in health economics based at the University of Oxford. And for the last year and a half, I've been involved in the locomotion study. So you probably came across it or even be part of locomotion. So it stands for Long COVID Multidisciplinary Consortium, Optimizing Treatments and Services, and it's an NIHR-funded research project. We have multiple universities, multiple teams seeking to optimize all aspects of long COVID care. And a key objective we have is to promote the vocational rehabilitation of long COVID patients. And here, I'll be presenting the preliminary results of the data we've been collecting from the study participants, looking at the health economic impacts as they themselves have reported, and then we'll be aggregating up to show the average impact and then extrapolating it outwards to see what kind of impact this is having at a national level. It is just the preliminary results. The data is still being collected, but we felt that there's sufficient data to kind of, announce the preliminary results. So the study population for this study and for locomotion in general is long COVID patients who are referred to a long COVID specialist clinic, so probably more on the severe side of the long COVID symptom spectrum. And registered on the digital platform provided by a company called Eleros. So the health economic questionnaire that collects the data we are interested in went live in August 2022. And for the preliminary analysis, we're interested in people who registered on that system for the first 6 months since it's going live, so up to about February 23. So this is a cross-sectional sample, and we have a response rate of about half, but thankfully respondents are representative of all the patients who've registered on the system during this period, and I think with the sample size now up to about 1,000, so hopefully we'll get a more kind of comprehensive analysis in the future. The data being collected in this questionnaire is mainly the productivity. We are collecting information on what people's productivity, that is, say, their work status, work hours, income, work performance, how health has impacted their performance at work, as well as there's some space for them to comment on long COVID's impact on their work and productivity. We're interested in these outcomes before people have had long COVID symptoms, pre-infection period, and also the previous months of the survey, so current as far as the survey is concerned. We also collected other health economic impacts, informal caregiver burden, and health and social care impact of the disease. We'll be covering less of these, focusing on the productivity today. This was complemented by various patient-reported health-related quality of life measures or health status measures. EQ5D is a measure of health status widely used by health economists. And C19YRS is the first validated health-related quality of life measure for long COVID. We also collected various social demographic variables, such as people's socioeconomic deprivation level and COVID-19 history, such as hospitalization for acute infection and their vaccination status. So moving straight to the results. So this is what the analysis shows. So from the sample, about 23.5% have reduced their paid work hours, but remained in employment. 16.7% are no longer engaged in work and receiving no work-related income. 11.5% are no longer engaged in work, but receiving some sort of work-related income through arrangements such as long-term sickness leave. 27% managed to return to the same work hours as the pre-infection period, and 3% are in fact working much longer, sorry, not much, higher hours than their pre-infection. So overall, more than half of the sample have had some negative experience regard to their work status and hours, whether that's reducing the hours or stopping work altogether. This is what happened to people's monthly work-related income. So you see the bars on the left in horizontal shading. This is people's pre-infection monthly income, and then the bars on the right is shaded in diagonally. There is their income in the previous months of the survey. And people who have had long COVID for more than 2 years have experienced the most decline in their monthly income, over 40% decrease. So they're under a lot of financial pressure. We also understand increase in how health problems have affected people's work performance uniformly, regardless of people's duration of having long COVID symptoms. We also collected some information on informal care receipts, partly because productivity loss occurs not just with the patients, but informal caregivers who have to reduce their working hours to provide care for their family or friends who are sick with long COVID. So around a third of our sample reported receiving any informal care, and of those, a quarter or whose caregivers reported reducing their work hours to provide those care, which averaged about 20 hours per week in the sample. So what we've done here is that we've taken the personal productivity loss as measured from the questionnaire and tried to extrapolate it to a national level. So what we've done is that we can estimate the, well, we know from the survey how many work hours people have lost per month. Using people's hourly wage, we can put some monetary value to that decline in working hours. That's an approach called human capital approach, rather crude, but it's widely used in health economic literature. And then once you have the monthly loss, we can calculate the aggregate loss from the people started their infection symptoms, long COVID symptoms, to the survey. So the kind of total loss at the individual level. And then we can aggregate to the national level because we know how many people nationally are in a similar situation as people in our sample. So, for example, we know that people, there were 364,000 people in the UK whose long COVID symptoms are affecting their activities a lot. So, assuming that these our long COVID sample referred to clinics are representative of these cohort of people in the national population, and we also have information on the duration of their long COVID symptoms. And using the average values calculated from our sample, we extrapolate out. So the total value or monetary amount of the productivity loss at a national level, we estimate it to be about £5.7 billion from when the long COVID emerged around 3 years ago. This obviously doesn't include the loss incurred by people with less severe symptoms whose activities are not affected a lot, but maybe a little, but still have some impact on how they work, how they function at their work. So this is probably on a more conservative end of the estimate. We've done something quite similar with informal care. We didn't actually include the working hours reduced by the informal carers themselves, but here we calculated saying that, well, if they weren't providing the informal care, those care would have been provided either funded by social care or purchased privately. So what are the values of the social or private care? And we can put a monetary value on informal care using what's called proxy goods method. And then the estimate comes out about £4.8 billion nationally extrapolated. So long COVID, from my estimate, has had about £10 million impact nationally, and it is an ongoing phenomenon. So with the sample data, obviously we don't lose opportunity to do some kind of a regression analysis, statistical analysis, and we found some interesting results. For example, longer the people's duration of long COVID, they are more likely to return to the same or higher paid work hours as their pre-infection period, and lower their health status, worse their health status as measured by EQ5D, they're understandably less likely. But interestingly, people with very long duration of long COVID are the same people who have very low EQ5D. So there are kind of two things going on. They're pulled in one direction, they're more likely to return, but they're also less likely to return because of their bad health status. So I think what's happening here is that people who've had long COVID for a long time are returning to work despite their worse health status relative to people who have had long COVID for a less period. It might be some financial pressure that's putting constraints and forcing people to return to their work. Another interesting result was that people who work in financial information technology and other professional managerial occupation have experienced a less decline in their income compared to the pre-infection period relative to the people who work in health and education. And this might be because they have more flexible work arrangements. So now just making some comparison to the UK general population. So the percentages here show the rate of economic inactivity or unemployment. So in the UK general population, for people aged 35 to 49, this rate is 14.5%. In our sample is 36.8, and the ratio between those percentage points are 2.5. So there's 2.5 times higher inactivity unemployment rate in long COVID patients compared to general population. For those aged 50 to 64, the ratio is about 1.4. So less than 35 to 49, but still elevated. The most impact has been felt by men aged 35 to 49. So in the general population, 9.4% inactivity unemployment. In our sample, 38.7, so a whooping ratio of 4.1. We can make some comparison to other patient groups. Look at the employment rate. Our long COVID sample had employment rate 53.5%. The chronic fatigue syndrome has actually a lower employment rate, 35%. And multiple sclerosis and breast cancer has similar employment rates to long COVID. But chronic fatigue syndrome has a much lower prevalence rate than long COVID, and therefore, if you do the extrapolation as we previously described, the annual value of productivity loss is much higher for long COVID. So we're putting in about 3.3 billion per year. Chronic fatigue syndrome is about 144 million. To put things into context, breast cancer, their annual productivity loss from new breast cancer cases is about 169 million per year. So this doesn't count the prevalent cases, so people who are diagnosed in previous years, but still, the breast cancer loss would have to be about 20 times higher to reach the figure of long COVID. So long COVID is having a very comparable, if not higher, impact on the national economy than other diseases. Because our study is still quite a small sample size, we wanted to put this into a bit of context, a bit of a convergence, and see how it's corroborated by larger studies slowly emerging in the literature. So Walker et al. 2023, I give reference for the studies in the last slide. They actually targeted a similar groups of patients. So UK long COVID patients referred to specialist clinics, and they found these results of 50.8% lost one or more working days in the previous month due to long COVID symptoms. And 20.3% lost almost all kind of working capacity, so 20 to 28 working days. So it's out of 28. So significant group has lost productivity altogether. And they famously said that the EQ5D health status measure is much worse than metastatic lung cancer with EQ5D of 0.54. I think lung cancer is about 0.68, 0.8 actually. So much worse health status than lung cancer patients. And in our sample, we found very similar results. And another study I wanted to raise attention to is Davis et al. This is an international sample with about a third of sample being UK-based. And we found very similar results in terms of people returning to work, reducing work hours, and having to stop work altogether. So conclusion is that there is a clear and converging corroborated evidence of the substantial impact of long COVID on productivity. And I think we can make a very solid health economic case for a greater investment in vocational rehabilitation strategies. As he described above, there's much worse labor market outcomes for long COVID patients compared to the general population, and similar, if not worse, outcomes than major diseases that's well known in the population. We can affirm the parliamentary report that long COVID is primarily an occupational disease affecting people in the working age band. And this research does incorporate the impact this has had on health and social care. So that work is ongoing using the same data set. As I just mentioned, I think any decently sized strategy will pay itself off if you consider the kind of productivity loss averted. So cancer drug, for example, costs around £630 million to develop. So if a disease modifying drug can cut the productivity loss by about 20%, it will, I think it should be able to pay itself off. So we hope to make a convincing health economic case for, going forward to make some further investment into long COVID care. Okay, so I'll finish there and wait for some questions at the end.
Thank you very much, Joseph, for a really important presentation. Some really shocking numbers in there. I think quite rightly we focus on the personal impact of long COVID on individuals, but perhaps, or your work's incredibly valuable in hopefully persuading the government that they should be taking things way more seriously, right from funding through to prevention of people catching COVID and prevention therefore of long COVID. So our next speaker is Alice Arkwright. She's policy officer in the Equality Department at the Trades Union Congress, the TUC. She works on a range of equality issues, including flexible working, young workers, and now long COVID. And she co-authored the TUC and long COVID supports report in March 2023 on the workers' experience of long COVID. And that's what she's going to tell us about now. So thanks very much, Alice.
Thank you so much for inviting me to speak. As Caroline said, I'm from the TUC, the Trades Union Congress, and a huge thank you to Joseph for that really, really interesting presentation, really shocking as well. I'm here today to talk about the joint report that the TUC wrote with long COVID support. And I just firstly, before I go into the survey, just wanted to firstly say a huge thank you to Jenny Ceolta-Smith, whose video you'll see later, Paulina Sparks, Leslie McNiven, Claire Rayner, and Kirsty Stanley, who all co-authored the report as well and put a huge amount of work into this. Working with long COVID long COVID support has been an absolute privilege to work with the charity. So I just wanted to reiterate my thanks before going into the results. My first slide was a bit of a background on the kind of impact we're seeing around long COVID unemployment and long COVID on the economy. I think Joseph has covered this really well, showing that sort of high level national data, but just to pull out a kind of few other things that informed the background to our survey. As Joseph very clearly said, we know that long COVID shows a higher prevalence amongst working age adults, and there is a higher prevalence amongst those working in health and social care and education. The ONS found that the number of people who are out of work and not looking for work due to ill health, although is just below the peak it reached in the third quarter of 2022, is still higher than before the pandemic. And this kind of high levels of economic inactivity has been linked to long COVID, amongst other issues, including mental health. The ONS produced a study which showed that data published in December 2022 highlighted that economic inactivity is rising 10 times faster amongst people with self-reported long COVID than those without. And we're also seeing kind of increase in sickness absence days. Sickness absence data does not include long COVID as a reason for sickness absence. So it's very hard to kind of draw fixed conclusions from the number of days we're losing to sickness because of long COVID. But you can see kind of things like respiratory conditions have massively gone up in comparison to 2019, although we know that there's a huge range of symptoms under long COVID, so that doesn't really capture the whole picture, but kind of gives an indication. So first of all, I'll just go into the methodology. So as I said, the TUC and long COVID work, so the employment section of long COVID support conducted a self-selecting online survey via SurveyMonkey from the 14th of September to the 1st of November 2022. And the survey was promoted via the TUC and via long COVID of work, so through our individual social media channels, through the TUC affiliated unions, and through long COVID support groups. To the TUC, we have 48 affiliated unions, and it was promoted through those. We received 3,373 responses from people who had COVID-19, and of these, we had 3,097 people reported that they had long COVID, from which these results are drawn. Just to give you a sense of who responded to those to the survey, so of the 3,097, 56% were in full-time employment, 24% part-time. 76% were women, so this survey is predominantly of women. 35% identified as disabled, 33% worked in education, 28% in health and social care, and 64% overall said they were key workers. So that just gives you a sense of kind of who we're talking about in these results. I'll just go to the next slide. So the aims of the survey in terms of what we wanted to find out was we wanted to do a rerun of a survey that we did back in June 2021 to kind of find out and sense check if anything had changed around people's experiences in work. And the main things we looked at is whether people experienced unfair treatment at work. And we also wanted to ask people about the types of reasonable adjustments they were asking for from their employer and the types of reasonable adjustments they were actually getting from their employer. And we also wanted to ask about other impacts it had had on their kind of working life, but also look at then the financial impacts, which Jenny will speak more on later in the session. So the financial impacts that long COVID was having. In this bit, I will talk more about the kind of work-related impacts. And as I said, Jenny in her video later will address the financial impacts. So the kind of these are two of the headline stats that we got from the survey, and that is around 2/3 of people reported experiencing some form of negative treatment at work. And in our survey in June 2021, it was around half of respondents. So we saw quite a big jump. It's obviously not a direct comparison. It's not the same people responding, but it kind of shows a general worsening of people's experiences. And 1 in 7 who responded to our survey said they had lost their job because of reasons connected to long COVID. Those people had then either stayed out of work permanently, some had retired, some had moved into different forms of work, but that's the kind of 1 in 7 had lost them a job due to reasons connected to long COVID. And that was nearly triple the number of people who said that in 2021, so it was 5% in 2021. So the kind of other two headline stats that we found from the report is not only are people experiencing very high levels of unfair treatment at work, including losing their jobs, but around half, so 49%, believe they caught COVID-19 at work. And then we also found there are very high rates of people who are not receiving the reasonable adjustments that they would like. So around half were not given any or all of the adjustments they asked for to support them at work. This next slide goes into kind of a bit more detail about the types of unfair treatment people are experiencing. So I'll just read this slide out. So around 1 in 6 respondents told us they had been subject to bullying and/or harassment. In the report itself, there's some really shocking quotes about the kind of comments people have received in workplaces and from their employers directly. So 1 in 4, 23% said their employer had questioned whether they have long COVID and the impact of their symptoms. So the theme of disbelief was really common. 1 in 4 said that the amount of sick leave they had taken had triggered an absence management or HR process. And actually on top of that, so 1 in 10 had told us that they'd used all of their sick leave and they'd been told there would be negative consequences if they took more. So for example, docking of pay or potentially putting onto a capability or disciplinary. And 1 in 13, so 8% told us they've been threatened with disciplinary action. So we're seeing a kind of range of unfair treatment that people are experiencing in the workplace by their employer, but by colleagues as well. And I just wanted to share some of the quotes from the report of what people told us, because I think they kind of paint that really human story of the impact that this is having on people's lives. So this first one is from a woman working in education. She said, "My manager does not fully understand the impact of long COVID and therefore has made comments which suggest she feels it is equivalent to her own tiredness and I should therefore be able to push through." This second quote from a woman working in health and social work: "I've been told by occupational health that HR will seek to remove me on grounds of capability if I don't come back to work soon." A man working in legal told us the impact on pensions and earning bonuses as not fit to work, so on half pay and unable to take extra shifts as I could do when I was well. And this final quote here says, "Absolutely awful experience losing my job. They ignored the advice of occupational therapist and instead went down the route of making me redundant. I was the only person in the whole organization made redundant." So what we're seeing here in these quotes is these kind of range of experiences, from losing hours, losing pay, losing work, being put on capability processes, employers ignoring occupational health and medical advice, and a lack of understanding from employers about the impact that this is having on people's lives. The next kind of big section of the report, as well as unfair treatment, was around access to reasonable adjustments. So I think people here will be familiar with, but I can go into in the questions around employers' duty to provide reasonable adjustments. What our report also showed that is a lot of people responding to the survey were meeting that definition of disabled under the Equality Act. So there was a substantial impact on people's ability to undertake daily activities, and they had been experiencing 12 symptoms for 12 months or were likely to experience symptoms for 12 months. So as I mentioned in our headline stat, half of people who didn't get any or all of the adjustments they asked for. But I just wanted to go through, there are kind of multiple barriers to people with long COVID accessing the adjustments they need to be able to work effectively. So first of all is the fear of telling your employer about having long COVID in the first place. So 1 in 9 hadn't told their employer about their long COVID symptoms. And that was largely because they lacked medical evidence. They didn't think their employer would do anything, or they were worried it would be viewed negatively. And I just wanted to emphasize that point about medical evidence, because under the Equality Act, medical evidence helps, but you don't necessarily need it to be able to access reasonable adjustments. So it's concerning that that's a barrier to a lot of people in terms of asking to start with. Of those who did share their symptoms with their employers, 1/3 didn't ask for any reasonable adjustments. And again, largely it was about a worry of being viewed negatively, a lack of a medical diagnosis, and they were worried it wouldn't be approved. And so these worries are not unfounded. Around 1/3, so 33% of respondents who asked for changes said their employer had made all the changes they requested for them to return to work, which is good, but it's worryingly low, and it is down from our report in 2021, where 44% of respondents said all of their changes had been made. So that, as I said, around half were not given any or all of the adjustments they asked for. And that was to return to work and then to manage their jobs as well. And I think a big theme that came out of the report as well was the stress of going through the process of asking for reasonable adjustments and not receiving reasonable adjustments is actually making people sick or more unwell. So kind of people coming back into the workplaces, not getting the reasonable adjustments is then making them more unwell and they're having to go off sick again. So it's this kind of horrible cycle of people not getting that support. To go into a bit more detail about the types of reasonable adjustments that people need. So I wanted to talk first of all about phased return to work, because this is very, very common. So we asked people what reasonable adjustments they asked for and what their employer gave, and phased return to work and access to occupational health, employers provided it more often than people asked for it. So 54% of people asked for a phased return to work, whereas 65% of people had it put in place, which implies employers are being proactive about giving phased return to works, which is good in some senses, but the narrative that came from the report is that employers are assuming a standard phased return to work is the solution. So you get your 4 weeks phased return to work, and then you come back and you should be able to do your job as normal. And we know that that's completely unrealistic for people with long COVID symptoms, given the fluctuating nature of them. So there was kind of little flexibility when people returned to work, and there was also little flexibility with the phased return kind of structure itself. And this quote on the side of the slide shows that kind of expectation that when you return, you should be kind of coping and acting as normal. These next couple of slides show the most requested reasonable adjustments. So in the table, you can see the adjustment that was asked for, the percentage of people that asked for it, and the percentage of people that received it. So the most common asked for reasonable adjustment was flexibility to support fluctuating symptoms. But as you can see, 54% asked for it, but only a third of people received that. The next was amended duties. This actually has a very similar kind of response rate, although slightly smaller numbers of people received it. And support from occupational health, as you can see, more people received that than asked for it. So again, implies employers are being kind of slightly proactive about providing access to occupational health, although it's still only around half of people who are receiving that. I won't run through all of the different numbers, just because I can share these slides afterwards, but you can see that again, so temporary changes to hours and longer or more frequent breaks. So this kind of flexibility in hours is really important in terms of a popular reasonable adjustment that people need. And we can see here that this 4 out of the 5 on this screen are also a type of flexibility, whether that be in your hours or in location. What I did want to highlight though is flexible working, whilst being one of the most needed reasonable adjustments, was often the hardest to get. So as I said, flexibility to support fluctuating symptoms, over half asked for it, but only 31% of people received it. Longer and more frequent breaks, again, 45% of people asked for it, but only a third got it. Permanent home working, 18% of people asked for this, but only 9% of people received it. And other changes to hours, 24% of people asked for it versus 15%. And flexible working options tended to have the biggest gap between asked for and received of all the reasonable adjustments, other than physical changes to the workplace, which also had a very big gap. So just on reasonable adjustments, obviously not providing the reasonable adjustments, there is a kind of, it means people aren't being supported at work, employers are not meeting a duty of care. As I said, it's leading to a cycle where people are becoming more unwell and having to take more time off sick. But it's also potentially a kind of risk to employers that if they don't understand their kind of legal obligations under the Equality Act and what that means in relation to long COVID, they're potentially breaching their duty to provide reasonable adjustments. I just wanted to say as well that another adjustment that was commonly asked for were kind of health and safety measures like mask wearing and ventilation. And we saw a lot in the comments of people asking for that, but it being turned down. I'll just quickly go through the recommendations that we make in the report. So for employers, we would recommend reviewing phased return to work policies, making these more flexible and more suitable for people experiencing fluctuating symptoms. Being more willing to offer flexibility in hours and location. We know there are a lot of people in health and social care, for example, who have had their duties changed, so they're doing more admin focused roles, but they're still not being allowed to work from home, even though they are working from a desk now. And introducing things like reasonable adjustment passports. So those adjustments are written down and agreed with the manager. So you have a written record of what you and your manager have agreed. This can then go with you when you move department, if you're redeployed, things like that, and making sure they're reviewed very often to make sure they're still working for the person. Just some other examples of really practical adjustments that we've heard about that have been helpful. So for example, disability leave. So this means that any sickness in connection to long COVID would not go towards your sickness absence record. Providing individual risk assessments for people with long COVID, because we know that reinfection can severely worsen people's symptoms. Things like suspending performance management processes or whilst people are waiting for treatment, for example, from a long COVID clinic, or waiting for redeployment or for reasonable adjustments to be put in place. Redeployment is obviously another option for people. Additional equipment. So as I said, there is specific health and safety equipment like PPE that people might need, but also things like ergonomic chairs for breaks. The kind of physical toll on your body of just sitting in a normal chair on your break can add to fatigue. Additional line management support. So kind of as people are coming back into work, that closer relationship with the line manager to make sure people are okay. For many people experiencing cognitive impairments, checklists for work can be helpful. So things like having a checklist of what you need to do that day, a process if your work is kind of process based. So these are the kind of practical things we've seen. I just wanted to flag our education unions have also developed a joint protocol which they're encouraging schools to sign up to around the kind of support that teachers and teaching support staff would receive. And the final thing we would obviously recommend is to prevent COVID-19 infection and reinfection. On the government recommendations, as I mentioned earlier, many people with long COVID will already be meeting the definition of disabled under the Equality Act and therefore are entitled to the protections against disability discrimination. But we would like the government to strengthen the Equality Act and have long COVID as a named impairment, as things like cancer and HIV are. We think this is important because it would recognise what people have gone through. So millions of people went out to work every day to keep this country running during a unprecedented pandemic, and the government has now offered them very little support now that they have become ill as a consequence of that. We think this would make it very clear to employers what their duties are under the law. There is still a lot of confusion around long COVID, and we think having that clarity in law would really help. And also, we know that we have an issue at the moment where we don't have case law around long COVID. So we haven't seen many cases reach a final decision at employment tribunal. There are many issues with the tribunal system. We're seeing backlogs of up to 2 years for cases being heard. And we also know that for someone with long COVID, the idea of going to tribunal is extremely difficult. It's extremely difficult for anyone, let alone if you're experiencing long COVID. So in an absence of case law, the government needs to make it very clear what employers' responses are. I think I'm running out of time, so I won't go through all these, but they are in the report if you would like to read them. But yeah, just thank you very much for having me. And these are all the references and a link to the report, and I will finish there. Thank you.
Thanks very much, Alice. Again, a really incredible report, really comprehensive and really shocking as well, and particularly shocking, I guess, in that it kind of lays bare how employers and the government seem to think we can all just forget about COVID present now and forget about long COVID as if it's all gone away, and that somehow people with long COVID have this linear recovery where somehow magically they're all just going to get better as long as they have a phased return. And yeah, so thanks very much. So Alice's colleague Jenny Ceolta-Smith unfortunately can't be with us, but she's pre-recorded a presentation. So Jenny is has been an advocate for long COVID support for over 2 years. She's co-author with Alice on the report that Alice has just presented data from. Her PhD focused on UK government policies related to the Department for Work and Pensions employment provision and frontline practice for people with health conditions who receive benefits. She's an occupational therapy, but she's also lived with long COVID for more than 3 years. And I just need to give a trigger warning on this presentation that there is a mention of suicide in the presentation.
Morning, I'm Jenny Ceolta-Smith and I'm pleased to have this opportunity today to share with you the TUC and Long COVID Support Survey Findings Part 2. I wanted to disclose my position here and to also highlight that I do receive benefits. I've only got 10 minutes and I've definitely got more slides than I can cover, so I'm hoping they'll be made available to you afterwards if wanted. But I'm framing the presentation around 2 key questions and looking at the survey results and other evidence, particularly patient-led. So just want to draw attention to what's already been said, that 1 in 7 workers lost their job. We know other workers have had to reduce their hours and pay. We're in the cost of living crisis, and there is good evidence to show that the costs of living are higher for disabled people than non-disabled. And there's also been an all-parliamentary group on poverty report just out recently on the inadequacy of benefits. And there has been a sustained attack on disabled people, for example, in the Telegraph, and you can read up about that through Disability Rights UK for further information. So I'm wanting to have a look at workers' experiences of any financial difficulties and also the experience of making a claim. We're talking primarily here about the PIP, Personal Independence Payment, now Adult Disability Payment in Scotland, and ESA, Employment Support Allowance, and Universal Credit. We asked workers about any financial support they received other than from Social Security, and you can see here that 41% relied on significant others, which included parents as well as partners and friends. We also see evidence of use of private loans, with a 4% considering these, and also that 1 in 16 of the people that responded were using a food bank. A small number of our respondents told us about the financial support they got when they left a job, and there were less than 2% who received ill health retirement pension or industrial injury payment. There was such uncertainty around the future financial situation for some of the respondents, and this sense of surviving, and a reliance too when someone had received a benefit that this could actually essentially top up the pay that they had lost. People told us how they saved money, and this included renewing a mortgage, moving to a cheaper house, selling possessions such as cars, jewellery, a motorbike, and saving on expenditure by not buying food, and some of these forms were quite risky. So within the survey, 19% of respondents were receiving benefits, and I think what's important to note here is that 38% of those that received benefits in the Employment Support Allowance group were medically deemed as unfit for work. And we can see that 6 in 10 of our benefit respondents were in receipt of personal independence payment. So from the responses we got around the experiences of claiming benefits, we had 2 key themes: the challenges with the process of making a claim and the worsening of an individual's health and well-being. Of real concern was the time it actually took to make an application, which ranged from 2 weeks to 2 months. Undertaking a claim while ill and living with cognitive dysfunction, debilitating fatigue, made the process really challenging, and it actually took some people up to 16 months before they were awarded a benefit. So in contrast, we see here that some people found the process quite straightforward, although there was a distinction made by two people where they found one benefit easier to apply for than another. The worsening of people's health and well-being is of real concern and indicated to be contraindicated to advice they'd received from medical professionals. People's description of the process revealed how traumatic the process could actually be for them. And we have some indication of real safeguarding issues, with two of the respondents reported feeling suicidal, and this was directly attributed to having to undergo the application process. We are aware of the survey limitations, and some of them are listed here. So in summary, people with long COVID, whether in paid employment or not, have experienced a range of financial challenges and hardship, with serious concerns about their financial future. The experience of claiming benefits while ill and living with multiple long COVID symptoms have been reported as variable, but the majority of responses revealed negative and harmful impacts that were experienced by people, with avoidable delays to receiving any financial support. I won't be able to go into specific detail about the evidence that's listed here, but I will draw on some key points as I show the slides. The Davis et al. Paper from 2021 highlights the need for some workers with long COVID to reduce their hours and consequently pay. The recent study by Remy et al. Talks about the financial pressure for people with long COVID and the association with suicidality, depression. And then we have the patient-led UK surveys, which I will be going into shortly. So back in 2021, our own online survey by Paulina Sparks showed that people weren't clear about what benefits they were eligible for. The Long COVID Scotland survey showed the increase in benefit claims and also draws our attention to perhaps the short-term nature of some award of benefits, such as employment support allowance. And the recent Key Worker Petition Campaign online survey highlighted again that people weren't sure about where to start with a benefit claim, and 69% of the people were actually struggling financially, and there is again evidence of people having to go to appeal a benefit decision. This year, the Royal College of Occupational Therapists reported that 70% of those with long COVID who had sought financial benefits had been unsuccessful. The locomotion study, through interviews, shows that workers have had to reduce their contracted hours by half and see a 50% wage cut. And also we have evidence of one person living on short-term loans. And the locomotion study also draws our attention to mixed experiences in terms of receiving support from the job centre. It's of real concern that long COVID is still not recognised as an occupational disease, and we have much more work to still do around the benefit system not being fit for purpose. We really have so many questions, and I've listed some here. Those of us living with long COVID are not okay, and we have serious concerns about the new proposals in the white paper that we will have to address. Despite the challenges raised today, people with long COVID are being awarded benefits, and there is support available. There is a PIP guide in the resources section today that I wrote with the support of a law centre in Greater Manchester, which may be of help. There's so much you can do as clinicians to support us in our benefit claims, especially giving us written documentation and evidence. Perhaps in your service you can discuss a way to standardise a template. I know some occupational therapists have such measures in place. To the researchers in the room, please collaborate with us. There's so much we need to explore. There is a data set sitting waiting that we can explore on the experiences of people with long COVID who receive employment support allowance too. It's important to acknowledge everyone that was involved in the long COVID support and TUC report. Thank you for listening, and I'm sorry I couldn't join you live today. These last slides are without commentary.
Presentation, that was fantastic. And for Alice as well. I should just mention that as Jenny isn't here to answer questions, Polina Sparks, who is part of the long COVID employment group advocacy team, long COVID support employment group advocacy team, is here to support Alice with answering questions. So I know we're running a bit late. We're going to try and get to the break at 11 o'clock and then take a 10-minute break. But Amy, if you want to go first with, you've been checking on the questions, I think.
Thanks, Caroline, and thanks to everyone that has put questions. There's some a really good mix of some quite practical questions, just in terms of, will you be publishing the research, as in sending around the links to people, which I'm sure we will do, to some really big questions. I think there's a couple in there for Joseph that I'd really like to pose, if that's okay. So I think everyone can really see how the findings of your research is really important in terms of trying to encourage the government to take more action, given the sort of really big numbers that you've come up with when you've been scaling it up. But we had a question from Jenny about how this information could actually also be perhaps useful in encouraging individuals to be more cautious and trying to avoid getting long COVID. So that kind of statement of, can you afford to get long COVID? And Jenny was wondering if there was any plans to use the data and the findings of the research in that way. And disseminate it more to individuals. The second question was about your predictions, if you have any, on when the impact of this might actually become unsustainable for the workforce in terms of teachers and health and care, and if you've done any sort of analysis on when you think we might not be able to meet demand that's being placed on public services. So sorry to put you on the spot, two pretty big questions there.
Hi. Regarding the individual impact, I think that I have some excellent colleagues within locomotion who do dig down to the individual level and kind of actually design rehabilitation strategies accordingly. I think Amy Parkin, I think she's probably on the call here. But certainly, yes. I think for further analysis, we'll be digging into, for example, comments that people have left regarding the impact that these has had on them personally. And if you can synthesize that, and it'll be a bit of a sober reading, I think, but we'll get the real personal flavor behind the aggregate numbers that we present. Regarding sustainability, there has been, there has been murmurings around that long COVID is responsible, some kind of the people dropping out of employment entirely in the UK. We digging into the impact on health and education will be a really good avenue of research. I did come across certain comments put by people saying NHS and the schools were very inflexible in their approach to handling the occupational challenges. So again, digging up that personal stories, and then aggregating out from the numbers to kind of national level of the implication of the workforce would be a really good research. And I think the all-party parliamentary group actually focused on the impact on the NHS. So in a sense, updating that report to show how many working days and hours have been lost in NHS in particular might be good. Health economists surprisingly don't do much capacity planning, but certainly we can dig into some methodology to estimate the impact that these might have had on NHS working. So thank you. I think those are more kind of research suggestions than
yeah, thank you. And there may be people on this webinar that will want to get in touch with you afterwards about that future research. So back to you, Caroline.
Yeah, so there's a few questions. I mean, we've only got a couple of minutes, so Alice and Paulina, I'm going to have to encourage you to be brief, but there's the questions after your presentation. There's a question about was there any intersection in the findings between work status and then typically marginalised groups, so lower paid workers, ethnically diverse workers. So we wondered whether you'd had that data as well. And then there's a whole set of questions which I think are kind of looking at the wider implications of your report for other things that the findings from your report might intersect with. So is there any data on people using access to work to support return to work? Are there specific recommendations for carers of people with long COVID? So for example, does the information you gave about employment rights apply to carers where people have had to give up work to look after their children? And someone's asked about could pension providers, would the information, your advice, be relevant or could be adapted for pension providers as well? So I don't know quite how you want to go split who answers which question. Alice, do you want to go first?
Yeah, I can do. I'll be very brief. I'd just say, unfortunately, we didn't get a high enough response rate from people from ethnic minority groups to be able to do a cut by BME workers. But just to say, there is around low paid workers in the ONS data, it does show that people living in, I think they describe it as deprived areas, are more likely to be reporting symptoms of long COVID. And obviously we know that then poverty intersects with kind of low paid work, insecure work, things like that, which will make accessing reasonable adjustments even harder. Access to work, we did ask a question about it, but I can't remember the answer, but Paulina might, so that will be a good one for her to come in. Carers for people with long COVID. We didn't do much specific analysis around carers, but I would say that flexible working, again, is key for carers. We know that is a big thing for carers kind of across different groups. So having that flexibility with hours and location can be a big help. So would encourage employers to put that in place for carers as well. We didn't ask specific questions about pensions, I'm afraid, but it could be of help, and very happy for people to share it with organisations if they think it would be helpful. Sorry, that was very brief, but maybe Paulina.
No, that's fine, that's great.
Yeah.
Paulina, do you have a quick comment?
I can ask that on access to work, it has generally been seen as a positive thing, I think, for people who have been involved with it. So, you know, from the perspective of the results of the survey and what we're seeing generally, it is a positive, you know, thing that can support people with return to work. We have not had this scope within the survey because we had to really limit the number of questions we had to ask also about caring and children, you know, generally caring. But there was a survey by long COVID kids, which might be worth referring to, you know, into the impact on families and carers. I would say with this as well, that you can see from Joseph's report, the kind of economic impact that is having, with people having to reduce hours if they're caring for a family member with long COVID. And from that report, we can extrapolate a lot. Regarding the minority populations, interestingly, we noted that the rate of response was lower from BME groups, and there was a survey separately in a group of minority people with long COVID that is going on, which will also look at why we're having those responses. And I think, to be honest, it is what you call intersectionality, that people are already facing discrimination somewhere else, and they don't want to bring more on themselves. In a way, they kind of disengage or deny their illness and don't want to disclose it because of the stigma they already face in other
Okay.
ones.
Yeah, thanks very much. Okay, over to you, Emma.
Thank you. So thank you very much. I think we're going to go for a break now, if that's okay. And if everyone can, if we're happy with a 7-minute break and we can start at 11:10, that would be fantastic. Just to ease the pressure on our next speakers. There's going to be a video played in the break from Eureka, one of our sponsors, and then we'll see you all back here at 11:10. Thank you very much.
Hi, I'm Zain, the CEO and co-founder of Eureka Health. Eureka is a website for patients to share their experiences trying different treatments to help everyone learn what's working and what's not. Our goal is to enable you, whether you're a patient, a clinician, a researcher, to find treatments that are most likely to work for specific types of long COVID. Now, we all appreciate the need for more research into more treatments, but clinical trials can be slow and expensive. Meanwhile, patients are often left navigating one-off anecdotes in online patient communities like Reddit or Facebook. And so that's where there's a significant data gap and where Eureka steps in. My personal connection to this is my mom. She was diagnosed with a chronic neurological condition about 5 years ago. Doctors soon ran out of treatment options, so we found ourselves turning to online patient communities. And although there's no cure, we did find a mix of treatments that helped her manage her symptoms, preserving her quality of life. Eureka is aiming to streamline this process. We collate data from these real-world experiences to offer better, faster insights. And we're not just helping patients. We're also giving researchers and clinicians more immediate data on what treatments are working. Today, we have over 23,000 treatment reports spanning across nearly 250 different treatments. And based on this patient-reported data, we're able to match individuals with treatments most likely to benefit their specific symptoms. So our mission is to bridge that data gap between patient anecdotes and clinical trials, and to foster a stronger link between patients and research. We're amplifying the patient voice and accelerating evidence generation. So if this resonates with you, I invite you to visit us at eurekahealth.com. Together, we can speed up the journey to understanding and managing long COVID, ME/CFS, POTS, and many other chronic diseases. Thanks to Long COVID Support for having us here.